Here we have multiple large nodules showing halo sign in male patient, 29 years old, presented with fever, admitted, and HRCT was requested. In literature, the most common cause of halo sign, as shown here in this HRCT, in the acute setting of fever, is angioinvasive aspergillosis, but this with a condition that patient is immunocompromised. Neutropenic patient, immunocompromised due to hematologic malignancy like leukemia, or having history of hematopoietic stem cell transplant. Otherwise, a patient is immunocompetent. This appearance is most likely due to non-fungal infection, either typical or atypical infection. This is the coronal scan, or another observation of how the halo sign looks like. Solid soft tissue density nodules with surrounding halo of ground glass. It's important with the history of immunocompromised neutropenic patient to strongly suggest the angioinvasive aspergillosis, because it's a serious condition and life-threatening. If no prompt management of antifungal infection is administered initially. But in case patient is immunocompetent, it will be the opposite. It will be nonsense to mention angioinvasive aspergillosis, as in this patient. And this is his X-ray in admission time. Then after 1 week of antibiotic therapy, as you see here, there's complete absorption of the pulmonary nodules, which means that mentioning possibility of angioinvasive aspergillosis in immunocompetent patient is nonsense. So my advice, reserve this diagnosis to immunocompromised patient, neutropenia, hematologic malignancy, leukemia, bone marrow transplant. Otherwise, the other non-fungal infection, typical or atypical, is more than enough to mention in your report. Thank you.